Hello, I'm Hematologist Oncologist Dr. Tony Talebi. Now we're going to discuss the management of stage 4 breast cancer, which is Her2Neu positive. I have the pleasure of being with Dr. Chuck Bogle, Professor of Medicine at the University of Miami. Thank you for being here.
My pleasure.
Okay, now let's take a scenario where a woman has a breast mass. For whatever reason, a CAT scan is done, and it now shows spread to other parts of the body. And the biopsy shows that the breast cancer is Her2Neu positive. What happens next for that woman?
Well, I make sure that I do an MRI of the brain because 30% of women with Her2Neu positive disease will at some point develop brain metastases, so I don't want it to sneak up on me unannounced. So then it depends on whether the patient has relatively indolent disease or whether they have very aggressive disease, whether they also co-express the estrogen receptor or not. So if a patient is Her2Neu positive and estrogen receptor positive and has relatively indolent disease, I might consider the possibility of starting with a hormone such as an aromatase inhibitor, either with Herceptin or with lapatinib. If one looks at the data from the two major trials that were done, one with Herceptin and hormonal therapy, the other with lapatinib and hormonal therapy, the lapatinib results look a hair better, perhaps, although the clinical benefit rate for both studies is identical. But the progression-free survival differences were better with lapatinib. But lapatinib is a bit more toxic a drug. So a lot of people, if they're going to give Herceptin and hormonal, are going to give a Her2Neu targeted agent and a hormone, a lot of people give trastuzumab, although in the study by Mark Pegram published, the results with lapatinib are looking quite promising as well. However, hormonal therapy just doesn't do very well in Her2Neu positive disease. If you look at the control arms in those two trials, where the control arm was hormonal therapy alone, the response rate was single digit, less than 10%. Whereas one would expect in the hormone receptor positive, estrogen receptor positive population as a whole, one would expect the response rate to be minimum 30%, clinical benefit rate 60%. You don't see that with hormonal therapy alone in Her2Neu positive disease. So I would not be very anxious to give hormonal therapy alone to a Her2Neu positive patient.
The patients always ask us, if the cancer has spread in multiple sites, is it possible to surgically remove all those sites, and can that achieve a cure?
Generally, no. Generally, it'll pop up elsewhere. In contrast to a disease like colon cancer, where if the disease spreads to the liver, you could remove a liver metastasis or even multiple liver metastases, and the 5-year survival rates are really quite good. That's been attempted in breast cancer, but I don't think the results are anywhere near as good as with colon cancer. And it is not my general approach to move in that direction.
So even if you have 1 or 2 lesions, you generally still will not perform surgery to remove everything?
Occasionally I would. If one had a local regional recurrence, let's say, I might be tempted to handle that local regional recurrence locally, then treat the patient aggressively with chemotherapy, and then if they hadn't been radiated to that area, radiate it, If they're hormone receptor positive, then add hormones along with the post-chemotherapy Herceptin and treat them as though they were a primary breast cancer. Then you might say, well, would you do that with an isolated liver metastasis, or would you do it with isolated lung metastasis? The answer is, I would discuss it with the patient. Would I be optimistic that that's going to be the answer? No. But one would really have to do the studies, randomized trials, to determine if that strategy would really hold up.
What about removing the primary breast tumor in the setting of stage 4 metastatic disease? Is that something you advocate or no?
It's a complex issue because there are at least 3 studies now that have looked retrospectively at women with stage 4 disease who have had surgical removal of the primary. And the big question you have to ask yourself is, why did some have removal and why did some not have removal? And so I believe that most of the positive results that one sees in those trials is due to selection bias. Though it is possible and that removal of the primary tumor in some way through the production of cytokines, stimulatory substances, if it were removed, might lead to improved survival, but I really don't know. And there is a clinical trial that is now ongoing looking at that specific issue.
I see. Now you mentioned medicines like lapatinib or trastuzumab known as biologics. What is the difference between biologics and chemotherapy?
Cytotoxic chemotherapy is, in general, not targeted. I mean, even chemotherapy is targeted. I mean, we have chemotherapies that are targeted against folic acid. So they're antifols. We have chemotherapies that are targeted against DNA. However, all of our cells have DNA. So you get DNA damaging agents and you're going to do damage to many, many cells. So drugs that are more specific, targeted to a specific target within the tumor cell, are more likely to have less broad side effects and toxicity on normal cells.
I see. What will lead you to straight towards using chemotherapy as opposed to strictly using hormonal therapy or biologic therapy in a patient with stage 4 Her2 positive breast cancer?
Well, as I said, I would almost never use single agent hormonal therapy in a Her2 positive patient because it's been shown that the likelihood of response is very, very low. It depends on the rate of progression of the disease, the degree of symptoms the patient is having, their estrogen receptor status as to whether or not I would choose hormonal therapy or chemotherapy.
I see.
And that would always be with an anti-Her2 agent.
As you know, most of our patients do take alternative herbal treatments. What is your stance on that in the setting of stage 4 breast cancer?
I tell them that, quite frankly, I don't know what most of these things are. They are highly touted in health food stores and online and different places, and I can't really keep up with it. And patients will bring me in reams of literature on the newest fad drug. A while back it was acai berries or whatever those were. And you know, we had shark cartilage, and there are hundreds and hundreds of these. Now there are a lot of mushroom extracts. So once again, I would rely heavily on somebody like Dr. Mehta, who has delved into some of these so-called complementary medications.
Mm-hmm. Do you find that they interfere with your chemotherapy regimen?
Don't know.
That's hard to say. How do you deal with areas of pain and bone spread, bone metastases?
Well, if there's a lot of pain in a given bone, you can radiate it.
Mm-hmm.
If you have widespread bone metastases that are too painful to radiate, you have to rely on analgesics.
Mm-hmm.
Very rarely we have to resort to pain control specialists, but for the most part, we have narcotic analgesics that can help to relieve pain.
How about a situation where a patient has no appetite? How do you help them through that?
Well, the classic drug that we use is Magisto Acetate,
Mm-hmm.
and in breast cancer, it's a two-edged potential benefit in the hormone receptor positive patients. Megase was actually our second-line hormone back in the 1970s, before we had the aromatase inhibitors. So back then, your first-line hormone was tamoxifen, your second-line hormone was Megase.
Mm-hmm. Mm-hmm.
And now Megase has been relegated to fourth, fifth-line hormonal therapy. So Magisto Acetate can be used as an appetite stimulant and could also be used as an anti-hormonal agent if the patient is hormone receptor positive. Another drug that we use is Marinol,
Mm-hmm.
which is a marijuana derivative
Mm-hmm.
that's taken orally and is legal.
Mm-hmm.
Beyond that, I would have to lean on people like Dr. Mehta to help to see if they have any other potential options.
Mm-hmm. I see. What about your recommendations in terms of exercising for patients that are receiving chemotherapy?
Well, I recommend that they exercise. A lot of them are too fatigued to exercise, but
Mm-hmm.
exercise is good.
Mm-hmm.
Exercise reduces obesity, which is good. You have to sometimes be careful in the real exercise enthusiasts, because if they've got bone metastases, they might want to overdo it on their weightlifting, and they could break bones.
Mm-hmm.
So there's got to be some caution. And here, when I have patients with widespread bone metastases who want to know how much they can work out, I send them to the physiatrist or to our orthopedic oncologist for consultation.
Mm-hmm. Now, you mentioned continuing the Her2Neu treatment, the first is trastuzumab. Do you continue that through second, third, fourth line chemotherapy? Do you continue the Herceptin?
Yes.
Mm-hmm. What about combining the Herceptin and the Lapatinib? When would you consider doing that?
Frequently. I use it really quite frequently.
Mm-hmm.
Can't tell you a situation where I would, but it's probably less. It can be less toxic than giving chemotherapy and Herceptin.
Mm-hmm. What are some of the common side effects associated with Lapatinib?
Well, the two major ones are diarrhea and rash.
Mm-hmm.
And it's an acneiform eruption that women don't like to get. Can be on the face, and that
Mm-hmm.
they don't like. Most of the time it's self-limited. There are treatments one can use for it, including both topical and systemic antibiotics.
Mm-hmm.
Diarrhea is more vexing, and you have to be very proactive in terms of your use of loperidine,
Mm-hmm.
Imodium.
Now, do you find that prophylactically using creams or antibiotic pills will prevent the rash from coming in the setting of Lapatinib use?
Not in my experience, but I haven't tried it.
Mm-hmm. How do you know the treatment you're rendering is working?
Well, if the patient has elevated tumor markers, the tumor markers will go down.
Mm-hmm.
If the patient is feeling badly, they're going to feel better.
Mm-hmm.
And then we have scans. So if they have measurable disease, we can follow them by scans.
I see. Now you mentioned there's some new treatments that are on the horizon, hopefully will be approved soon. Let's talk about the first one, TDM1. Please explain what that is.
Well, actually, TDM1 is not the first one. The first one to market will be pertuzumab.
Okay. So let's talk about pertuzumab.
Okay, pertuzumab is what is called a dimerization inhibitor.
Mm-hmm.
And this is easier to talk about, if one had graphic aids, but basically, if one thinks of a receptor as, here's a receptor, it's a finger. In order for the substances that trigger this receptor to send signals into the cell to stimulate tumor growth, it's got to partner up. It's got to hook up. It's got to marry somebody.
Mm-hmm.
And it can marry another Her2 molecule, or it could marry one of the other hair molecules. There's Her1, Her2, Her3, and Her4. And probably the preferred marriage partner is Her3.
Mm-hmm.
And so if Her2 and Her3 hook up together, that then forms a very strong signaling mechanism to send word down to the tyrosine kinase domain, which is where lapatinib works,
Mm-hmm.
Which then sends signals through a pathway, sort of looks like a subway system,
Mm-hmm.
down into the nucleus, where it stimulates cell growth. And so you've got these two guys that want to pair up,
Mm-hmm.
and pertuzumab prevents that.
Mm-hmm.
It is a dimerization. This is a dimer, and pertuzumab prevents dimerization. And as such, it has proved to be a very potent drug to combine with trastuzumab. And ultimately, it will prove to be a potent drug to combine probably with TDM1 as well. We've done those studies,
Mm-hmm.
preliminary studies.
And what is TDM1?
TDM1 is a cool molecule. TDM1 is a Trojan horse. Basically, the way it works is there is a chemotherapy drug, and it's not a drug we commonly use. In fact, we never use it. When I was a young oncologist, about your age,
Mm-hmm.
We were studying in the phase 1 working group of the National Cancer Institute a drug called maytansine.
Mm-hmm.
The maytansine was highly toxic, so it never made it through the major mechanisms. So what the scientists at Genentech did was they took a maytansine-like drug and they hooked it to trastuzumab with a linker. And the linker is the key. That's the genius of it.
Mm-hmm.
Because what happens is the trastuzumab takes the chemotherapy and brings it directly to the target cell, the cancer cell,
Mm-hmm.
and does not release that drug until it gets in the cancer cell. And then the linker breaks.
Mm-hmm.
Now, if the linker broke too soon, you would have a lot of toxicity. And TDM1 is a beautiful drug because it causes very little in the way of systemic toxicity. Women don't lose their hair.
Mm-hmm.
They don't vomit. They have virtually no toxicity.
That's amazing. I hope that it hopefully will be approved at some point. How do you deal with depression in the setting of incurable stage 4 breast cancer?
Well, there we have to rely on our psychiatrist, and antidepressants work, counseling works, and group sessions can work, and psychotropic drugs work. So it's a combination of all of those.
Now, there are some agents that protect the bone, such as bisphosphonates or denosumab. Please explain what those are and how to utilize them.
Well, when a patient has metastatic disease to bone, we do have drugs that can help to prevent fracture. Now, again, when I was growing up in oncology, we didn't have these drugs. And so we had patients in the hospital all the time with pathologic fractures. You don't see that today. And you don't see that today because of drugs like zoledronic acid and now the newer drug, denosumab. So it's changed the life of many patients and changed the life of many doctors because I don't like going to the hospital. And somebody breaks a leg, you're in the hospital. So what these drugs do is they don't necessarily kill cancer cells, although they may. And that's a subject of tremendous study right now, whether these drugs have any intrinsic effect on cancer cells themselves. But what they do is they antagonize a cell called the osteoclast. The osteoclast is part of the bone remodeling system. And the bone is a very dynamic place. And you have the osteoblast, which makes bone, and you have the osteoclast that is like a Pac-Man, and it eats up bone. And cancer cells elaborate substances that stimulate the osteoclast. And the osteoclast then chews up the bones. And both zoledronic acid and denosumab both are anti-osteoclast drugs. And so that's really how they work.
I see. I know that you personally are a champion of clinical trials. Would you please explain to our patients what is a clinical trial and do you recommend it?
Well, I've been doing clinical trials for 35 to 40 years. And it's through clinical trials that we make advances. And I hear from patients, I don't want to be a guinea pig. I would say that anybody with Her2Neu positive disease, if they are not in a practice that is doing clinical trials and doing a lot of clinical trials, they are in the wrong place. Because right now, the most important drugs for Her2Neu positive disease are not available other than through clinical trials. And so certainly in Her2Neu positive disease and in virtually every other aspect of cancer medicine, clinical trials are of critical importance. It's your only way of getting the newest, potentially better drugs than the average oncologist in the community has access to. And I personally feel that many of our oncologists in the community are doing their patients a disservice by not participating in clinical trials. And that's why I've spent probably 25 years of my life developing clinical trials apparatuses or apparati in the community to provide the infrastructure for private practicing oncologists to do clinical research. And patients need to know that if you're a part of a clinical research project, you're not going to be deprived of standard therapy. You're going to get whatever medical science thinks is standard or something that we hope is going to be better. You can't design a trial to find out if something's going to be worse than standard therapy. So our hope is that the investigational arm of a clinical trial is going to be better than the standard arm of that trial. People worry about placebos.
Right.
Most of our trials don't use placebos. There are places where placebos are perfectly reasonable options, and that is because there would be a situation where there is no known effective therapy. And so you need to try to add this new agent to a situation where there was no effective therapy before. And because there is a placebo effect, meaning that if people were in this trial, a lot of them think, even if they weren't getting the drug, that if they were on the placebo, that they're actually getting better. And so in order for us to know with certainty that the drug is truly effective, for certain studies we do need to have a placebo. But even in a placebo-controlled trial, the patient is not denied any known effective treatment. They will get the standard treatment.
Very nice. Some of our patients sometimes confuse palliative care versus hospice care. When do you think each is appropriate? Would you please explain that?
Well, a palliative care is what we do for every patient, or most patients with metastatic cancer. Palliative care, as of 2012, we, in essence, cannot cure metastatic breast cancer. I have a few patients in my practice I think are probably cured. And most of them tend to be Her2Neu positive, by the way. But for the most part, we can't cure it. So the goal of treatment is prolongation of life, and if the patient has symptoms, palliation. Palliation is relief of symptoms. So palliative care means that we are just relieving symptoms. Now, the patient may have symptoms and they may live another 10 or 12 years, and we can help to relieve their symptoms during those next 10 to 12 years of their life. So that's very different than hospice care. Now, hospice care I reserve for patients where we have exhausted all conventional forms of therapy and have to move from a philosophy and goal where we are emphasizing hope and cure, or hope and remission, to an acceptance that we have fought a good fight, that we have done the most that we can do, and it's time to rest. And it's time to be made comfortable.
How do you make that determination, and how do you have that discussion with your patient that it is time to transition to hospice?
It's always a very difficult discussion, and it's a difficult discussion depending on the personality of the patient. There are some patients who are more realistic than others, and there are some families that are more realistic than others. And sometimes the two may not necessarily coincide. And therein lies the bigger dilemma, where the patient really is ready to let go, and the family is not willing to let go. And that becomes frequently a very unpleasant tug of war. But I just sit down with the patient, and they've known all along, since I've been caring for them, that I've been trying to get them into remission. I've been getting them into remission. Most of them have had long periods of good disease control. And I would just frankly tell them, we've gone as far as we can go, that you fought the good fight, and it's time to let go.
Very nice. I think even in the setting of incurable disease, patients still want hope from us. how are you realistic but at the same time hopeful?
I tell the patients that we're making advances every day, that we never know when the next magic bullet is going to come, that they've just got to continue the good fight, waiting for the next good drug to come. And I have patients, I have Her2Neu positive patients right now who have exhausted many avenues, and I say, listen, keep going. We got pertuzumab coming, and I think pertuzumab could make a difference for you. And so you're usually able to continue to instill hope. And usually it turns out to be a very abrupt end. When you move from the emotional sphere of encouragement and hope and fighting to the concept of moving to hospice.
Thank you so much. Thank you for watching. We hope this has been educational.